Good afternoon, and thank you for joining us for the final plenary of our Maria Users Meeting. Today's session is titled Using Community-Level Data to Improve Understanding and Prevention of Maternal Mortality. As many have noted throughout this meeting, understanding the drivers of disparities is critically important to addressing inequities in maternal mortality and preventing future deaths. Today, we will hear from 3 speakers on a proposed framework for using community-level data to understand contextual factors with subsequent research using the pregnancy mortality surveillance system data linked to community-level indicators to understand how place and social context influence maternal mortality. We hope these data will inform the work of MMRCs as it relates to data collection, identifying contributing factors, and developing strategies for prevention. So first, we will hear from Dr. Michael Kramer, an associate professor of epidemiology at Emory University. Dr. Kramer is a maternal and child health social epidemiologist with research interests in social and contextual determinants of geographic, racial, and economic disparities in maternal and infant health outcomes. He is the program director of the HRSA-funded MCH Center for Excellence and principal investigator for a CDC-funded project developing and evaluating maternal mortality review committees and health equity toolkits. Then we will hear from Toby Merck, a public health analyst with the CDC Maternal Mortality Prevention Team. Toby is a presidential management fellow and provides technical assistance to states through the Enhancing Reviews and Surveillance to Eliminate Maternal Mortality, or the ERASE-MM program, and analyzes geospatial factors to explore associations with pregnancy-related deaths. Lastly, we will hear from Chloe Barrera. Chloe is a PhD student in epidemiology at Emory University. She is also a guest researcher with CDC's Maternal Mortality Prevention Team. Her research focuses on social and spatial factors associated with maternal mortality. So now I'd like to hand it over to Dr. Kramer, who will be our first presenter for the day.
Great. Thank you so much, Shauna. It's really a pleasure to be here with you all today. Some of you who are here I have met before at prior Maria users meetings, and many of you are new, and it's really great to have us all at least virtually together. So this session, I think, builds so well on some other topics that have come up over this 2-day experience. I was so moved by the opening session today, and particularly by the powerful story that Janelle Palacios shared about her family and about her people and about the role of history and context in shaping health. Thinking about Dr. Hardiman's talk yesterday and the emphasis on our understanding of the role of context and structural processes in shaping health. Those are themes that motivate this session. What we're going to present today is information on community level data that can improve our understanding of maternal mortality. To be clear, this is just a little step in the direction of fully engaging with all of the historical and structural processes that are important, but hopefully one that is useful and achievable by each of us in our state MMRCs. So this is information that we know. This is simply a figure that tells a story that we've heard in many ways and that motivates so many of us. These blue lines are the pregnancy-related mortality rates for every state. And you can see that they range from 30 per 100,000 live births down to less than 10. In other words, there is dramatic variation in the occurrence of pregnancy-related mortality across states. And then you see at the top in those squares the racial disparities, Black-white racial disparities and Native-white racial disparities in pregnancy-related mortality ratios. So sometimes when we see these things, we see them often and we sometimes feel like these are inevitable or fixed. But when we see data like this, what I see is opportunity to change something. If there are states that have a pregnancy-related mortality ratio that's below 10, why can't every state have a pregnancy-related mortality ratio below 10? So what these disparities tell us is that we have a lot of work to do, not that anything is inevitable. Now, we've been engaged with many of you, with many folks at CDC and in states across the country in thinking about what are some of the ways that we can bring data and new kinds of information to bear to help us do a fuller, richer, more complete job of telling the story of the tragic deaths of women during and following pregnancy. So one piece of this, not the only piece and not the end all, but one piece of tool set that can help achieve those aims is the Health Equity Toolkit that we've developed as consisting of a conceptual model, a set of data indicators, and then a tool that helps maternal mortality review committees take community level factors and translate them into specific recommendations. Now, a key part of this is the conceptual model, and it goes back to what does it mean to tell the story of what causes the sequence of events that result in death. And so we have this as a simplified version of what the evidence shows to date in terms of drivers of the health of anyone, but particularly the health of pregnant women. So this conceptual model centers on the pregnant woman. At the bottom, beneath the skin, we have the biology, the underlying health and physiology. And this is, of course, where many of our committees spend a lot of our time discussing things. It has to do with her cardiometabolic health, her neuroendocrine health, her immunoinflammatory health, and that the interaction between her health and the clinical care she received. So clearly, these things are important. But in addition, we know that it's not only the events that happened in labor and delivery or during pregnancy, but that each pregnant person was a person before they were pregnant, and that they had a lifetime's worth of experiences, things that influenced their health. So we're critically aware of the role of the life course and preconceptional health, reproductive planning, adverse childhood events, opportunities and constraints across the life course. Now, when we think above the skin, when we think about the world that each of us navigates a world where we daily make decisions and choices that influence our health. But of course, not all of us make decisions and choices from the same menu, so to speak. We all make decisions and choices based on a set of constraints and opportunities. And those things are shaped in lots of ways. They're shaped by social constructs like race and class. They're also shaped by community environment. So we can think of the community environment as sort of a risk regulator, as something that shapes the ways that individual people can navigate and find health and opportunity. So when we think about the community environment, we divided it up into several buckets or chunks. We could think of the general health environment. So the health of everybody, that's true for not just specific to reproductive health, but clearly the reproductive health environment is also salient. The behavioral health environment, transportation, and then critically important is the social support environment, which is both within the family, in social peer groups, and in the community. And then overarching all of this is a recognition that communities did not just crop up in a vacuum, that the patterning of resources and opportunities in space and to groups happens in systematic ways that are tied to history and tied to structural inequality. So these are the fundamental social determinants of health. They include things like historical genocide, slavery, Jim Crow laws, but also contemporary things like the persistence of unequal policing and residential segregation. And then finally, we have this loop that goes back from the risk regulators back to under the skin. This is something Nancy Krieger calls embodiment, which is the idea that any of us literally biologically embody the social world as we move through it, either by the privilege we have that helps us stay healthy, or by the experiences that stress us or that weather us. So the idea that embodiment can lead back to the very physiologic things that we may read in the medical record, things like obesity and hypertension that are very relevant to any particular case. So that's a conceptual framework of summarizing the evidence for what are things that might be important in pregnancy. So how can we link that conceptual framework to specific cases that are being reviewed in your committees? One thing that we set out to do was to try to find data indicators. So we have data indicators that are measurable at geographic units all across the country that align with each of those domains: the general health environment, the behavioral health environment, the socioeconomic environment. The particular indicators here are just examples. There's many other indicators that would be possible. And then we combine that all together into what is this current version here of something we call the Community Vital Signs Dashboard. And this is simply a visualization of the context of a specific woman. So this would be one dashboard that gets connected to one case and is a tool for providing contextual information that can hopefully change the conversation about how committees understand the lived experience that she had in that place. Now, I'm not going to go into more detail about the dashboard right now. I have talked about this at previous Maria users meetings. I will just say that over the last year, we're wrapping up a one-year implementation pilot with Illinois and North Carolina. And we're planning actively now for a website that will make the dashboards available to any state who wants to use them. And we're also in active discussion about ways to increase technical assistance for states who are either interested in adopting this health equity toolkit or many other creative innovations that states are coming up with on their own. So that is one strategy, this idea of providing these particular data. But a gap that has remained is the conceptual framework, and those indicators were based on a literature review of what do we know about other maternal and child health outcomes. And that's partly because we have a big gap in our understanding of the specific contextual drivers of maternal mortality specifically. So today's speakers are going to begin to fill some of that evidence gap, and they're going to do it by presenting results from an analysis of the pregnancy mortality surveillance system. This is one of the most reliable national level estimates of pregnancy-related mortality. And what's unique is that it has recently been geocoded so that it's actually possible to come up with estimates at the county level with protection of privacy, of course. I'm going to say a little bit about the data before I hand it off to my partners who are going to give you some more information of the results. So again, the data are this collection of all pregnancy-related deaths. This is from 2011 to 2016. There were some deaths in the original PMSS which were excluded because they had missing information on geographic data or race ethnicity. Ultimately, the data that you're going to see in just a moment represents 3,747 pregnancy-related deaths geocoded to the county level. And then they're linked to age, race, year, county-specific births in order that we can actually talk about pregnancy-related mortality ratio at the county level. So with that, I'm going to hand it off to Toby Mert, who is going to present some of those findings.
Thanks, Michael. I really appreciate the handoff. And so to talk a little bit about some of our findings, the first question that we really wanted to answer with this data set was, how does urbanicity or rurality affect the risk of pregnancy-related death? And we know a few things. We know that the population distribution in rural and urban areas varies by race and ethnicity. For instance, non-Hispanic white persons comprise a majority of rural and suburban populations, while the proportion of non-Hispanic Black persons living in urban areas is more than twice the proportion living in rural areas. In addition, rural areas face unique health challenges. For example, all-cause mortality is higher in rural areas than in urban areas. Access to hospital-based obstetric care in rural areas has declined, resulting in more mothers giving birth prematurely and delivering in facilities that lack obstetric services. We also know that the prevalence of delivery hospitalizations due to substance use disorder is highest in rural areas, as is the uninsured rate. So in this initial analysis, we aggregated pregnancy-related deaths from PMSS by year, racial ethnic group, maternal age group, and 5 category urban-rural grouping based on the National Center for Health Statistics Urban-Rural Classification Scheme for counties. And in this analysis, we used a unique approach to estimate the birth denominator for the pregnancy-related mortality ratio, which is the number of pregnancy-related deaths divided by births times 100,000. And this estimation method involved multiplying state-level fertility rates by county-level population counts of women ages 15 to 44 years. And then we aggregated those county-level estimated births into the same 5 NCHS urban-rural classification categories. So this is just to show what those 5 categories are. This is the NCHS urban-rural classification scheme for counties. We use the 5 levels shown in the middle of this figure: large metropolitan, medium, and small metropolitan as the metropolitan areas, or the non-rural, the urban areas, and then micropolitan and non-core as the rural areas. And as we looked at our data, we found no difference between large central metropolitan counties and large fringe metropolitan counties. So we collapsed these into a large metropolitan category and proceeded with 5 different NCHS urban-rural classifications. In terms of our findings, this figure shows what we found on the urban-rural distribution of pregnancy-related deaths by race and ethnicity. And not necessarily surprising, but the number of pregnancy-related deaths decreased with increasing rurality. The proportional distribution of pregnancy-related deaths by urban-rural classification level within racial and ethnic groups shows some more interesting results. In particular, the vast majority of deaths among each group except American Indian and Alaska Native persons took place in urban areas, specifically large and medium metropolitan counties, the blue and orange sections on the left-hand side of the figure. In contrast, more than half of deaths among American Indian and Alaska Native persons occurred in rural areas in the non-core and micropolitan counties. We found, generally, that the pregnancy-related mortality ratio increases with increasing rurality. We found the lowest PRMR at 14.6 in large metropolitan areas, and the highest PRMR was found in non-core areas, the most rural areas, 23.8. The last slide compared the pregnancy-related mortality ratio across urban and rural categories. But within each urban-rural category, the disparities by race and ethnicity mirror the disparities we observed and have observed in other analyses at the national level. The PRMR for Black persons was 3 to 4 times the PRMR of white persons within every urban-rural category. And the pregnancy-related mortality ratio for American Indian and Alaska Native persons was 2 to 3 times higher than that of white persons in small, micropolitan, and non-core counties. When we stratified by age, we saw that the pregnancy-related mortality ratio didn't change much for persons younger than the 30 to 34 age grouping by urban and rural category. However, we noticed some drastic differences between rural, again, those are the micropolitan or non-core counties, compared to urban areas, the large, medium, and small metropolitan counties, among persons ages 35 to 44 years. And the spikes that you can see in this figure in both the 35 to 39 years and the 40 to 44 years age groups represents a PRMR in rural counties that's about 2.5 to 3 times the PRMR in large metropolitan counties in the same age groups. So in this initial analysis, just to summarize our findings, we confirmed in this analysis that geographic location is important and that there are notable differences both across and within urban and rural areas. We found that the pregnancy-related mortality ratio among older persons increased with increasing rurality, while the PRMR among younger persons was similar generally across urban and rural categories. Again, we noticed the disparities are mirrored those that have been previously observed at the national level. Differences across among geographic location groups, rather, may reflect the intersection of age, chronic health conditions, and access to care, including risk-appropriate care, while differences among groups by geographic location may reflect the intersection of interpersonal racism or implicit bias, as well as structural racism as manifested in residential or economic segregation, for example, which are both linked to poorer health outcomes. I'll now turn it over to Chloe to talk about the next analysis.
Thank you, Toby. And hi, everyone. Thank you all for joining us today for this presentation. I'm excited to share our recent preliminary research using PMSS data to look at variation in pregnancy-related mortality ratio by sociospatial indicators. With this study, we wanted to contribute to the knowledge gap in the multi-level drivers of maternal mortality. And to do this, we used where a person lived in order to characterize her community. Well, we know it's inadequate to focus on individual risk factors alone to reduce population-level health disparities, especially given between group Black-white racial disparities persist, even among women at otherwise low risk. Therefore, contrary to conventional assumptions about individual factors like advanced maternal age, cesarean delivery, obesity, and chronic health conditions being the drivers of maternal mortality, we sought to build on some of the existing knowledge base of studies that have incorporated the context of larger structural determinants like county level income and higher percentage of women having not completed high school, and explore how additional social and contextual community factors may help to characterize the communities in which women may be at a higher risk for pregnancy-related deaths. So we are interested in sociospatial measures that tell us about the supply of health services, the demand for health services, or how healthy is the population, measures of population health status, and measures of the socio-contextual environment outside of healthcare. We are interested in indicators that we could obtain across all states so that they would be scalable, and then this resulted in a set of 31 county-specific quantitative indicators, which we assembled from publicly available data sources, such as the American Community Survey. So these domains represent the broad community barriers that may be influencing the ways a woman navigates preconceptual, perinatal, and postnatal health. For example, here we have the demographic context where we looked at things like education level, both those who do not have a high school education and those who have even more than a bachelor's degree. Then within health context, we looked at things like the number of OBs in the population, as well as percent of low birth weight births. Within the social capital and social support context, we look at things like the violent crime rate in the community, as well as the percent of people in the community who do not speak English or who do not speak it well. And then within the socioeconomic context, we looked at things like food insecurity and percent of households without a vehicle. So a little bit about our analytic methods. What we ultimately wanted to learn is how the average environment of women with pregnancy-related deaths is different from or similar to the environment of all live births of women in the community. In order to answer this question, we aggregated death and birth data by year, racial ethnic group, maternal age group, and FIPS region. And FIPS region is another, we can essentially turn that out for county. So then we merge these sociospatial indicator data with the birth and data by these county codes. So because we're analyzing the data in a multi-level framework where individual women are nested within counties and within years, we needed to use general estimating equations. These enabled us to estimate the absolute ratio difference in pregnancy-related mortality for women living in counties with higher versus lower values of each sociospatial indicator, while accounting for clustering of women within the counties. We standardized the measure so that a 1 unit change is the same across all indicators and represents a 1 standard deviation increase. So what that means is that all of the regression estimates are comparable. And what we are calculating is the risk difference. So in other words, for counties that have more of that factor, what is the PRMR, the pregnancy-related mortality ratio, compared to counties that have the average amount of that factor? And we were mindful throughout this work to make clear that the associations we are exploring are attributed to structural issues and structural racism and not necessarily an individual's race or ethnicity. We believe this quote from a recently published paper emphasizes this well. That is, treating race ethnicity as a confounder may emphasize behavioral and biologic explanations for associations, whereas instead stratifying by race ethnicity to evaluate effect modification can focus findings on structural factors such as transgenerational poverty and residential racial segregation. In other words, when we treat race as a confounder, we are eliminating the effects of racism on the associations we are observing. But when we stratify by race, we're able to see how an association differs between individuals of different races, highlighting the structural factors contributing to the observed disparities. And just to quickly touch on the most basic aspects of when we stratify versus adjust. So when there's a single measure, when there's a single exposure of interest, and we are interested in whether the effect of the exposure on the outcome is different across strata of a third variable, we are interested in effect modification, and we want to stratify on that third variable. For this analysis, we had 31 individual exposures of interest, and because we know pregnancy-related mortality varies between races, we also expected to see the measure of association to be different between women who are Black, Hispanic, and white. Confounding, on the other hand, is a bias that distorts the measure of association. When we think of variables as a confounder, we adjust for it with the aim of eliminating the effect of that factor on the exposure-outcome relationship. To try to eliminate the effect of race, or really racism, in regression models would mask important racially patterned differences in exposure effect relationships. And this paper is particularly interesting for talking about confounding versus effect modification because we actually looked at both. So as I mentioned earlier, we looked at a variety of indicators across 4 main domains, and while I think each are worthy of taking an in-depth look at, for the purpose of this presentation, I've chosen to focus on the health context domain, and specifically the indicator for percent of low birth weight births. Here, we are seeing the pooled results from our analysis, which represents the exposure-outcome relationship among all races. The pooled analysis adjusts for year of death, age group, county population size, and census region. Now, the interpretation of this modeled ratio difference estimates is the change in pregnancy-related deaths per 100,000 live births for each 1 unit increase in the sociospatial indicator. That is, for counties with a 1 unit increase in percent of low birth weight births, there are 6.42 excess maternal deaths per 100,000 live births. I want to emphasize that this does not say that low birth weight births cause pregnancy mortality, but what it means is that counties with a higher than average percent of low birth weight births also have a high pregnancy mortality rate. Now let's take a look at the measures of association when we adjust for race or treat it as a confounder. Here, we see the risk difference declines from 6.42 in the pooled model to 3.02 in this adjusted model. And as I mentioned, adjusting for race tends to explain away the impact of racism on the association. So now we're looking at the model that is stratified by race ethnicity, or treating race ethnicity as an effect modifier. We can see that most of the association we observed in the pooled result is driven by the experience of non-Hispanic Black women. In counties with a higher than average percent of low birth weight births, non-Hispanic Black women had 6.21 excess deaths, whereas Hispanic women had 2.64 and white women had 1.96. Finally, just to pull it all together, I have all the models here side by side, which is how results are presented in the paper. So this figure illustrates what we saw in Model 2. The race ethnicity adjusted summary, but for each indicator we examined. We can see that some factors are protective. These factors down here to the left of the line are having more of these things is associated with a reduction in pregnancy-related mortality. Things like median household income and the number of OBs in the community, whereas having more of these things, such as food insecurity, and you can see the vast majority here, are associated with higher pregnancy-related mortality. So I found it especially interesting that the number of OBs per capita had a significant but minor impact on pregnancy-related mortality. Often, we think that the solution is just to have more OBs in the community, but this indicates that it is not the main driver of pregnancy-related deaths. Again, this is just an exploratory model, not a causal model, but the relatively modest effect of OBs is interesting. So because it was a bit hard to read on the previous figure, I wanted to take a moment to highlight the community indicators that are most impactful for non-Hispanic Black women. Again, these are factors that characterize communities in which women are also more likely to have pregnancy-related mortality compared to communities with the average level of that factor. These are structural issues that were associated with at least 5 excess maternal deaths among non-Hispanic Black women. and included percent of adults 25 and older without a high school education, an increase in low birth weight births, teen pregnancy rate, percent of women who are uninsured, prevalence of obesity, prevalence of poor, fair, self-rated health, number of retail opioid prescriptions, neighborhood deprivation index, unemployment, percent of the population below the federal poverty line, and food insecurity. And then here are the factors we found to be most protective. That is, a greater percent of college-educated adults, number of mental health care providers, and a higher median household income were all associated with at least 5 fewer pregnancy-related deaths. So, in summary, we found that maternal mortality varied across counties and by race ethnicity, and that many sociospatial indicators were associated with county-specific pregnancy-related mortality ratios, independent of age of the woman, the population size, or the census region, and that magnitude of the associations varied by indicator and also by race ethnicity. And thank you all. I look forward to our discussion.
I would like to say thank you to our 3 presenters. That was really interesting, amazing, lots of great questions. This has truly highlighted that with data, place matters when we're discussing opportunities to address maternal mortality. So I really hope this session helps us think beyond the patient and provider level and pushes us to examine community level indicators, not only for opportunities for prevention, but also which communities can benefit from coordinated action. So there were a few questions around the methods that were presented here. So I'll start with you, Toby. Can you comment on the categorization you presented on non-core, central, large metropolitan areas? So can you talk about that strata a little bit more?
Sure, thanks for the question. So these are strata that the National Center for Health Statistics Urban-Rural Classification Scheme for counties publishes, which are based on OMB classified metropolitan statistical areas into 6 different categorizations. So there's large central and large fringe, which both can be kind of aggregated up into a large metropolitan category. There's medium metropolitan, small metropolitan, micropolitan, and non-core. I realized on the slide, I don't think there was a definition for non-core. So just for everyone's awareness, non-core are non-metropolitan counties that did not qualify as micropolitan. And micropolitan counties were urban clusters with a population of 10,000 to 49,999.
Thank you. So just to let all participants know, Toby's paper is in the American Journal of Obstetrics and Gynecology. We tried to drop the link for participants. Chloe's paper is still preliminary results, but there were lots of great engaging questions about the methods that were used in the indicators. So there are questions around the source of the data and the indicators that you use, specifically around residential segregation, what the source of that data was, and then also other care providers such as midwives and CNMS providers. Did you look at those providers in your model?
We considered looking at certified nurse midwives, but there wasn't enough within each county to make it easy to look at. So we ended up removing that. And I do have a table that has the source of each indicator, but I do not have it right in front of me. So that will be in the paper.
And I can say a word about the source. So the segregation data come from, they're actually available in a number of sources. The Census Bureau actually produces that. I believe somebody dropped a link in the chat as well. And the segregation data is specific to a metropolitan area or a county, whereas other indicators are only at the county level. And that has to do with kind of what segregation is, which is not something only constrained to counties. And there actually, we may have another data source for nurse midwives that combines not only certified nurse midwives, but also advanced practice nurses. So there may be an opportunity to enrich that.
So that just shows that these comments are really helpful for us refining this analysis. There were another comment around retail opioid prescriptions. Michael or Chloe, did you want to comment on the source of that data?
So those particular data are available from a couple different sources. The one that's, I think, in this analysis is from the Robert Wood Johnson Foundation's County Health Rankings. They produce those data points, but actually CDC also releases data not only on opioid overdose mortality, but also on pills dispensed per 10,000 people or per 1,000 people. So there are measures of that at various geographic scales.
Yes, and so there was also a comment around the March of Dimes maternity care provider deserts. So again, something to consider, but as Chloe noted, very interesting finding that OBGYNs was not strongly associated in the model. So with our 10 minutes left, I wanted to kick it off some other questions as participants are thinking. So Chloe, you found that the effects were larger among Black women than white women. You presented why it's important to do effect stratification versus confounding. And did you or any of the panelists want to comment on why you thought you saw a stronger association among Black women on the same scale compared to white women?
Sure, and thank you. It's a good question. So I do think it's important to emphasize that these associations aren't causal, but rather they provide context into understanding the characteristics of the communities in which women are more likely to experience pregnancy-related mortality. And the unfortunate reality is that Black women are more likely to die from pregnancy mortality than white women. So it was expected that we would see stronger associations among Black women than white women, which can only be, partly explained by the larger political and structural determinants that have led to deprivation in communities and structural racism that we're all working, learning so much about and working to dismantle. But because these issues impact Black women uniquely, unfortunately, it's just something that, we expected to see within the data.
I thought I might also just, since you opened it to other panelists as well, Shauna, I think, earlier today we heard about the importance of talking about the background story. And I think, here we have the differential access to opportunities and exposures that shape people's lives. I think what we're seeing in some of the racial and ethnicity stratified data that Chloe presented is really how structural racism shapes life experiences and opportunities, that a person's exposures or access to resources may depend on this social construct. And that the same environment does not necessarily present the same harmful or productive exposures or opportunities, to Black and white persons.
And so there were another question around neighborhood segregation. Did you take into account concentration of extremes to account for various measures of segregation while avoiding multicollinearity?
So Chloe, I think, did you have a model earlier on that used the ICE index? This is the index of concentration at the extremes. That certainly is something we've evaluated, and I don't recall the result off the top of my head.
Great.
Okay. Now, I also don't recall the result off the top of my head, but I remember we decided to take it out because we felt like there were other measures that were capturing the same concept, but were more easily to interpret.
So, one sort of broader comment as I was kind of looking at that chat as it was coming in as well, when we think about, we say that place matters, but when we think about, well, how does place matter? It actually isn't like a one size fits all. So the idea of whether your neighborhood matters, or your county matters, your metropolitan area matters, it probably depends on the thing that you're measuring. So when we think about one way that sociologists and demographers often talk about residential segregation is it's something that happens in a housing market, which is not a neighborhood. It's the housing market is like the Atlanta metropolitan area is 28 counties. It's huge. That doesn't mean that your neighborhood also doesn't matter. It's just that social and structural processes happen at different scales. So ICE is a measure that's really good at telling us something about the local structure. So it would be good at the neighborhood level, possibly at the county level. Whereas residential segregation tells us about a regional process. And I think we want to deal with both of those because the idea of building context isn't that we're trying to get as close to an individual level variable. It's that we're trying to describe the forces that shape opportunity. And segregation doesn't shape opportunity only at the neighborhood level. It does it because it limits or facilitates residential choice and educational opportunity across a metropolitan area, for example.
Thanks. That's really important context to point out. So there's some comments around the factors for the Hispanic population. In your models, it showed that the effects were not as strong, but can you speak a little bit about what your models did find for the Hispanic population and the factors that you identified?
Yes, so we did look at each of the indicators among Hispanic women individually, just as we did among Black and white women. And for the most part, Hispanic women had very similar estimates to white women. Some of the ones that were stronger were things like the teen pregnancy rate. I'm looking over here at my other tables, and also a number of retail opioid prescriptions, but they didn't have any indicators near as strong or as shocking as the non-Hispanic Black women. It looks like Shauna might be.
Maybe Shauna is frozen. I'm just looking over at the other chat. I can maybe bring some questions in. Okay, so Toby, one question about the rural-urban analysis was, maybe you touched on this already, was an evaluation taken into account for deliveries in an urban area with residents in a rural area?
So I guess that question kind of gets at rural residents that are traveling to urban areas for care.
Mm-hmm.
That's a great question. The answer is no. This was, since it's based on PMSS data, is really kind of limited in the amount of data that we have on an individual case, and certainly would benefit from a data set that is captured in Maria, for example, that has a lot more information about the care that a person received, where they lived, what their individual experiences were, as well as this larger kind of community level context.
So this actually brings up, I think, a great question that also came up in the chat earlier. There was some comment about the limitation in the PMSS analysis to county variables, whereas the community vital signs dashboard does actually include neighborhood variables too, census tract level variables. So what that means is each of you all are part of creating the surveillance data that's going to be helpful for enriching this. The PMSS is just limited in the kind of data that's available, including it's at the county scale, and as Toby said, limited information about the clinical care. That's obviously the reason for MMRCs, is to enrich the quality of the story all across the experience. And so I think as we get more and more data, as states are producing their own data and using it locally, and also as we're pooling it nationally, we'll be able to continue to build on that. So I see that we have 2 minutes, and I know that we have the graphical summary of this, and so maybe we could see how this session was summarized. I love these, they're just so great. And if Julie's available, we might welcome her in as well. There we go.
Yes, thank you. Thank you so much. I want to give folks a chance to look at that beautiful visual recording. So much to see here. And of course, this is available in the resources tab in the SwapCard platform. So please be sure to review this one there, and also all the other visual recordings and other resources that we have available. I just want to thank you all again. Thank our speakers for being here. Thank you, Michael, Chloe, Toby, and Shauna for a wonderful session on using community level data. The threads of data in context that Magda spoke to, and data in view of the intersectionality that Rachel spoke to, really came together as we looked at these PMSS data. Dr. Hardiman called on us yesterday to center in the margins. These indicators we just saw can help MMRC members see context or what structures surrounded her. What shoes was she walking in? Coupling that with the individual level information gleaned during records abstraction and informant interview can be so powerful in understanding the fuller picture of her life and the events that led to her tragic death. These data points will allow MMRCs to illustrate structural contributors to disparities and how they contribute to pregnancy-related deaths. As we draw to a close, I just want to thank you again for being here over the past 2 days. I know I'm feeling even more inspired to continue this work, this journey with all of you, and I hope you are too. I guess I don't know that any of us ever thought this work was easy, but echoing the words of Dr. Palacios on deafening silence, we can no longer remain silent on the undeniable influences of structures that disproportionately favor some over others. Our committees must recognize structural factors and address them during case reviews. Further, our work, our mindfulness and storytelling and how we communicate racialized data and convey these incredibly heavy data points on maternal mortality in context makes all the difference. So thank you again. Some of us will now be going into breakouts by region. But first, I have a message for everyone who's on the platform right now. I ask you again to please complete the evaluation before leaving the platform. An evaluation survey link is available in the resources tab, and it also should be dropped into the chat momentarily. I want to thank all the folks who have been involved with the Maria user meetings over the years. This is our 5th one, as you can see in the Roman numeral in the name. And actually, we built this entire session in partnership with AmChip around your evaluations from our last Maria user meeting in December of 2019. So taking your feedback and building this content is really something that we glean from those evaluations. So please, please, please complete them. Please continue to stay engaged with us. And we look forward to continuing the journey with all of you. So please take a break, take a little self-care, and those of us who will be in the breakouts, be sure to join us for your regional breakout at 2:50. Thanks again. Have a good one.